Good afternoon, everybody, and welcome to today's live webinar, whereby we will be reviewing the results from the 2024 EQA scheme on lung cancer testing using liquid biopsy. This webinar is a non-promotional webinar organised and funded directly by AstraZeneca. Next slide, please. A couple of housekeeping notes first of all before we get going. So your microphone has been automatically muted just to avoid any background noise. We record all of these webinars to allow you to listen back at your own leisure and time. Normally takes a couple of weeks before we can make it available to the audience on the EMQN and GenQN YouTube channels, but we will let everybody know when that's available. And most importantly, this is supposed to be an interactive webinar as well. So you have the opportunity using the Q&A session, Q&A button at the bottom on bottom on your Zoom browser to ask us questions at the end. We've got time set aside at the end where you can put your questions to us. And of course, we encourage you to do so to get the most out of the webinar as well. Next slide, please. Feedback. So like all of our webinars, we value your feedback. It's important to us. It helps us improve the quality of what we're doing. So you will receive an email after the webinar with a link to a short feedback survey. Strongly encourage you to complete that, please. Normally takes no more than 2 minutes. That will help us to ensure that we provide webinars in the future that meet your needs as well. Next slide, please. Our disclaimers and disclosures. Next slide, please. So this webinar today, the objective we're trying to achieve, if you like, with the webinar is to make sure that you have an overview of the results from last year's liquid biopsy EQA for lung cancer. We want to give you some clear examples of errors and pitfalls seen in that process. Don't forget we have a broad range of number of laboratories participating, so we've got a really good idea of how laboratories perform with respect to lung cancer testing. Liquid biopsy, which went to help you prevent or rectify common issues. We've also provided and ensure we can provide guidance on reporting results, particularly within different clinical contexts. All our EQAs are designed to sort of challenge in a number of different clinical contexts. And as I said before, an opportunity for you to ask questions in the Q&A session at the end of it. So it's interactive. Please do contribute to that process at the end. Next slide, please. So I'm joined today in the presentation. This is a joint EQA between EMQN and GenQA. So I'm joined with my co-chair, Professor Sandy Deans from GenQA, Director of Genomics, and myself from EMQN. I'm going to hand over to Sandy to do the introduction part of the webinar. Over to you, Sandy.
Thank you, Simon, and I'd just like to join you in welcoming everyone to our webinar today. So next slide, please. So I'm going to set the scene and give you some background of what we're doing and why we're doing this external quality assessment scheme. So the aim of the EQA is to assess the testing accuracy and the clinical reporting of EGFR gene variants, which is mandatory for participants to report the results from those tests, and also KRAS, which is optional. And the reason that we include KRAS is we know that some laboratories include this target as part of their routine testing, and it's really important that laboratories don't need to change their routine testing to participate in EQA. So if you do test and report KRAS variants, then we want you to do that for the EQA, but we do not want the laboratories to have to stand or introduce any further testing that's not routine practice. The idea is to help improve clinical service using a combination of the assessment, but also more importantly, the feedback from our expert panel. So we provide individual tailored laboratory feedback through your individual laboratory report on either deductions or comments, and sometimes some nice positive feedback comments as well to each laboratory. And we also provide overarching EQA summary report summarising the expected results, the validation process, perhaps a range of the different technologies used in laboratories, and any errors and issues that arise. So the format of the EQA really is accessibility of the participating laboratories to One, correctly determine the genotype of the sample. So basically, the sample is tested and you report the correct result. Interpret those results in response to the clinical referral in a clear format. So each EQA case is provided with not only just with your sample, your plasma sample for testing, but also a clinical referral. So you can interpret those results within the context of that clinical case. We also would like to see the correct use of internationally accepted standard nomenclature, which is particularly important when it comes to using databases and sharing data, genomic data. We need to make sure that we're speaking the same language. And also to provide appropriate and accurate patient and sample information and identifiers. So we're ensuring that the right patient is being reported. Next slide, please. So one thing about the delivering EQA is we can actually start to see what is happening in laboratories. So here you can see over the years, we've now performed 5 years of ctDNA testing for lung cancer. And you can see that our participation has always hovered around the sort of 50 different laboratories. It's dropped slightly in 2024. And also you can see the number of participating laboratories has dropped slightly, but we still have a vast number of laboratories across many, many different countries participating. Here you can see the spread of the location of the countries, and I think just the take-home message here is it's truly global. It's not just within one continent, we really are across the whole world. Next slide, please. Because of this, we are aware that different laboratories use different testing strategies. So we need to make sure that the samples that we provide for testing is fit for purpose for whichever laboratory, however they're performing the test and wherever they're performing the test. So we have manufactured 3 custom artificial plasma samples from SenseID according to our specification. So we have 3 mils of artificial plasma, which includes 80 nanograms per microliter of cell-free DNA. These samples are validated before they're sent to EMQN and GenQA using droplet digital PCR by the manufacturer. However, as I mentioned, we need to ensure that once the samples have been distributed from the EQA provider and tested by different methods, the results are still reportable. So we make sure that the genotype of each EQA sample is validated independently by 3 different laboratories by 4 different methods. And we know what that genotype should be, so we can be assured that the actual sample is behaving in the way that we're expecting. So this year for the 2024 EQA, we performed validation using the Roche Cobas EGFR mutation test, which is widely used and has been for many years. We also validated using the droplet digital PCR using custom biorad primers, next generation sequencing using TrueSight Oncology ctDNA specific panel, and also the Guarded 360 diagnostic assay. Next slide, please. So as I mentioned, EQA really gives you a snapshot of what is happening at that time across the globe. So here we can see the different testing methodologies that are being employed by the participating labs. So on the left-hand side here, you can see the different types of technology. So you've got next generation sequencing, PCR-based, droplet digital PCR based, a laboratory developed test, and a strip assay. And then when you can see the different types of assays, we can look at the data in a different way. And not surprisingly, you can see next generation sequencing being the most frequently used. And I think over the years, we can map that this has increased, whereas before it was very much targeted assays that would take were the dominant method of testing. Here you can see the change into next generation sequencing. Next slide, please. So let's start looking at the EQA results and some of the outcomes that we can share today. So we have 3 cases that Simon and I are going to talk through. This is case number 1. This was a patient who was presented with pneumonia and an image showing a mass on his lung. So he had already been diagnosed with non-small cell lung carcinoma, and molecular testing of the plasma sample had been requested. And with all these cases, really to determine potential further treatment options. So again, just to reiterate, the testing of EGFR gene was required, mandatory, and the testing of KRAS was optional. So the validated results were that there was no actionable variants present in the sample for EGFR gene variants tested in these 4 exons. There was an expected pathogenic variant in codon 12 of KRAS, and the expected variant allelic frequency was around 2%. And this was backed up also by the participant mean, which was hovering just over the 2%. However, we had genotyping errors, so this is where the incorrect genotype was reported by 7 of the participating laboratories, so hovering around the 3% mark. We also had critical interpretation errors, whereby the incorrect patient interpretation was provided by smaller number, but again, 3 laboratories. Next slide, please. So this is a summary of the critical genotyping errors. So here you can see there's a whole range of different reasons for the incorrect result. We had one laboratory reporting a deletion, an exon 19 of EGFR, which was incorrect, and a second false positive result where they reported the presence of a different EGFR variant. We had 3 laboratories reporting false negative results, so they did not report the presence of the KRAS variant. We don't know whether they missed that due to the bioinformatics pipeline, or they actually did not actually detect the variant. We had 1 incorrect variant reported, which was the presence of a KRAS variant instead of the one that actually was truly present. And we also had a final laboratory with a potential swap of the EQA samples. Now, we don't know whether that could be a sample receipt, whether it was during processing, extraction, testing, or reporting, but it indicated there was a mix of the samples during the EQA. Next slide, please. For the 3 laboratories reporting critical interpretation errors, again, you can see there's a range of reasons. 1 incorrectly stated that the results could be interpreted as potential response to EGFR TKIs, which is incorrect. 1 further laboratory incorrectly stated that the KRAS variant is responsive to KRAS TKI therapy. And 1 laboratory overinterpreted the results. So they suggested that there are improved treatments for the KRAS variant in this case. So although drugs are currently in development targeting this specific KRAS variant, they're still very much in the trial phase and therefore not approved. So the expert panel and the assessors decided that it was inappropriate to include this statement on the report. Next slide, please. Simon, I'm going to come to you for case number 2 in a moment, but just to summarise, I think for case 1, that the common deductions here that we could see in this context of the clinical case was the overinterpretation of the absence of an EGFR variant. Now, we know that testing circulating free DNA and assays performed when an EGFR variant is not detected, it's too strong to suggest that there's an unlikely to be a response to EGFR TKIs. And the reason behind that is because you're not absolutely confident that you're actually testing tumor DNA, because in the background of the circulating free DNA, you have normal DNA present as well. So it's all dependent on the background. We also saw many laboratories not recommending testing of a tissue biopsy or a repeat sample. As I say, again, this backs up the fact that you did not detect an EGFR variant. And also, as we see over and over the years, and here it's recurring issues across the EQAs, is failing to provide sufficient information regarding the methodology used and the limitations of that assay being performed. And that is really critical for the reader of the report to understand where they may not have been able to detect the variant using the method and the testing strategy employed. Next slide, please. So, Simon, over to you to summarise cases 2 and 3, please.
Thank you very much indeed, Sandy. So, case 2, this was a lady who had previously been diagnosed with metastatic lung adenocarcinoma, and molecular analysis, or previous molecular analysis, had shown the presence of an EGFR L858R variant in her tumour. So she'd been prescribed first generation TKIs, and after initial response, the tumour was now progressing. So testing had been requested on the plasma sample to determine the correct treatment choice now that she's progressing. So in this sample, the validated results were we weren't expecting to find any actionable variants in KRAS, but we were expecting the laboratories to be able to confirm the presence of the L858R EGFR variant at an expected VAF of 3%. The participant mean was just below that, so that's good to see a reflection of the validated data. But more importantly, we're also expecting the laboratory to identify a resistance variant, so T790M, in the patient, present at a VAF of about 1.5%. The participant mean just over 2.8%, so slightly higher than expected, but nevertheless still lower than the L858R variant in EGFR. So this is a scenario where the patient essentially has a resistance variant, and we're asking you whether they will respond to a treatment option in conjunction with that resistance variant. So looking at the errors made by the laboratories, so the genotyping errors, as Sandy said, these are errors that would potentially cause patient harm, critical issues. There were 5 genotyping errors across all the cases analysed, so about 2.1%. And there was 1 interpretation error as well, so just under 0.5% as well. Next slide, please. So looking in a little bit more detail at the types of errors made by the laboratories. So there were 2 false positive results. So one laboratory incorrectly reported the presence of a ROS1 fusion, and the other laboratory reported the presence of a deletion, so a different variant, so deletion in exon 19 of EGFR. There were 3 false negative results. So 2 laboratories found the L858R variant at about 3%, but did not detect the resistance variant, the T790M variant, at 1.5% VAF. And 1 laboratory reported the T790M, so the resistance variant, but did not report the original sensitizing variant, which is the L858R at 3%. Looking at the critical interpretation errors, so the laboratory that made the critical interpretation error stated that the T790M variant confers resistance to EGFR TKIs, which is true, but without mentioning that it confers sensitivity to 3rd generation TKIs, and therefore the patient may respond as a consequence of treatment with a 3rd generation TKI. Next slide, please. So common deductions for this case. So unsurprisingly, I think really is not understanding the presence of the resistance variant indicates that the patient has a likelihood of benefiting from a 3rd generation TKI. Interpreting the results in the incorrect clinical context. So we very clearly stated in this clinical scenario that the patient had already had molecular testing, and the sensitizing variant had the L858R variant had already been detected. So in this case, laboratories lost marks if they did not include that in the clinical context. So they didn't mention that the patient had previously been treated with other EGFR TKIs. And presenting separate interpretations for the sensitizing variant and resistance variants at the same in 2 different reports. So this is, again, something we see reasonably frequently, although it is reducing, which is good to see. But it does have the potential to cause confusion for the reader. So the overall interpretation, summarising the cumulative effects of all the testing, if you like, summarising it all within the specific clinical context should be provided clearly. And it's not helpful for the end user that they receive 2 different separate interpretations of the variants tested or detected in this patient sample. Next slide, please. So moving on to case 3, this was a patient, a lady who had presented with a persistent cough and shortness of breath. So a mass had been detected on imaging, and she'd had EBUS samples taken as well, which showed the presence of a TTF1 positive malignancy, but there was insufficient material available for molecular testing. So metastases to the liver have been visualized on imaging, and testing of the patient's plasma has been requested to determine management. So in this scenario, it's not easy to get a real tissue sample, and so the use of a liquid biopsy sample from the patient's plasma have been requested to try and drive a decision making about what's the best approach to take for her treatment. Again, like case two, we weren't expecting laboratory to detect any actionable variants in KRAS. But we were expecting laboratory to detect a G719S variant in EGFR at about 2% VF. That's the validated result. The participant mean was slightly higher, 3.59%. There were quite a lot of genotyping errors associated with this case. So 14 out of the 242 cases tested, so about just under 6% of laboratories made a genotyping error. There were no interpretation errors, which is great to see. Next slide, please. So digging into more detail about the types of errors laboratories made, the genotyping errors, there were 5 false positive results. In one case, the laboratory reported a different variant in EGFR, an insertion deletion variant. A laboratory reported the presence of a p-Val 769 MET variant. One laboratory reported the presence of the T790M variant. One laboratory incorrectly reported the presence of another deletion in exon 19, and a laboratory incorrectly reported the presence of a KRAS C35G2A variant. There were 6 false negative results where the laboratories failed to report the G719S variant in EGFR. And then there was the one laboratory that, as Sandy alluded to in case 1, had a potential sample swap between case 1 and case 3. So they reported the presence of the KRAS C35 G2A variant. There was also a case where a laboratory incorrectly reported the patient name. Now, patient identifiers are really crucial on a clinical report. And so we do deduct if laboratories mix up the patient name, because obviously that's providing the end user with the wrong information about the wrong patient tested. So in this case, the genotype was correct for case 3, but the laboratory itself reported the patient name for Antonio Fontes, which was case 1. And finally, there was some conflicting results between the results section and the interpretation section in one report from one laboratory, which put the results of the test in doubt. So again, the information provided about how the test was done and how they interpret the end result was inconsistent between the two. And in those cases, that laboratory would also receive a deduction, in this case, a critical genotyping error, because it gives the wrong information relating to the test result. Next slide, please. So looking at the common issues associated with this case, the main issues were incorrectly reporting the type of EGFR TKIs that might be appropriate in this case. So G719 variants in EGFR have been shown to respond to both first generation, second generation, and third generation TKIs, depending on the study it's reported in, but nevertheless, this response has been demonstrated. Failing to provide insufficient information regarding the methodology used or the limitation the test performed. So again, this really reinforces the information from case 1, which Sandy reported on, which is understanding how you do the test and how you report the test, understanding the real limitations of what you're doing and the impact of that on the end result in the context of this test. Next slide, please. Sandy, I'm going to hand over to you for the observations.
Thank you, Simon. And can I just encourage you, if you would like to submit some questions, then please use the Q&A function that you see at the bottom of your screen, because Simon and I would be very happy to cover anything that you would like to ask about the EQA run in 2024. So I have 4 slides that I'm just going to talk to you about some of the general observations that we can feed back to you from the results of this EQA run. So as I mentioned previously, testing circulating tumour DNA in the background of cell-free DNA requires the use of methods that are more sensitive than those required to test DNA extracted from solid tumour tissue. And that's just because the level of the circulating tumour DNA is so much lower than expected, and much lower than what you observe in actually solid tumour tissue. So it's not appropriate to use an NGS assay developed for solid tumour tissue testing with a limit of detection about 5 to 10%, or even Sanger sequencing. And many years ago, when we started these EQA runs, you could see the majority of EQA participants did actually use Sanger sequencing, which has a much higher limit of detection. So clinically, you want to go down much lower to your lower variant allelic frequency. The amount of ctDNA present in plasma can vary, but it is generally lower, as I mentioned, in tumour biopsies. So it's been suggested, and it's variable as to the level of detection that clinical users would like laboratories to test down to, but it has been suggested that assays detecting variants at 0.01% to 0.1% should be utilised for testing of cfDNA. And I think it really depends the clinical case and also your clinical teams as to whether they would act upon detection of variants at this low level. However, these methods may not be able to simultaneously detect different clinically relevant variants. Some assays can go down to this low level, but only focusing on a particular variant or two. Therefore, you need to get that balance about the choice of your method, which is used to achieve a limit of detection below that 1% mark. So you have to compromise. You have to understand the limitations of your test, the limitations of the assay in your hands, in your laboratory, and the balance of the scope of the variants to be tested and what sensitivity you want to be reached for your clinical service. Next slide, please. The other area that we often see many deductions being made through the EQAs is about the use of standardized nomenclature. So HGVS nomenclature was used correctly by the majority of laboratories. And this is fantastic news because it is something that we monitor a lot. We're both EMQN and GenQA are very committed to ensuring that standardization is put in place when you come to reporting your variants. So we had 25 laboratories, so about 10% of participants received deductions for either the incorrect use of or not using HGVS nomenclature. And this was up at 18% in 2022 and was about 6% in 2023. So we can see a general trend of improvement. So I think maybe we'll put a positive spin on this year and say 90% of laboratories didn't receive deductions for their HGVS nomenclature. One of the other things that we're quite adamant about is this is a DNA-based test. So we're expecting the variant to be described in terms of your nucleic acid change. So it's what you're actually testing. And the predicted amino acid change, so that protein nomenclature is about prediction of what happens at the amino acid level. We're not actually performing any protein testing. So as I say, it has to be a predicted change at the protein level. We know that some of the commercial kits report the result only at the amino acid level, and it's not possible, sometimes dependent on the assay, to actually determine or characterize that nucleic acid change. But it is possible to state that that's not possible, and you also can use HGBS nomenclature to indicate that you cannot actually determine the nucleic acid change. It's not recommended to use the for example, X nomenclature, as the 3-letter amino acid code is preferred. Now, it's not incorrect according to HGVS, but it's better practice to actually use the 3-letter code, because then you're minimizing any misinterpretation of that genotype result. Next slide, please. The third area is about gene reference sequences. We went through a change of using LRGs and also other reference material, reference sequences. And during that period of transition, we saw many laboratories using more than one gene reference sequence per report. And this was really confusing. So very clear guidelines are to only state one gene reference sequence on your report for each gene. So both EQA providers support the use of the main select and the main plus clinical as donated by the main initiative. And here you have the references of where you can get that information. And that is to help with the standardization of variant annotation, interpretation, and reporting. You can still use the locust reference genomic reference sequences, the LRGs, and they are still acceptable, but RefSeq and ensemble transcripts are specified by main, so they are more preferred because it does just help to standardize and again minimize any misinterpretation. So we had about 6% of laboratories, 15 of them receiving deductions for not including a reference sequence on the reports. And again, you can see that this is a great improvement. We had 12, nearly 13% receiving deductions in 2 years ago. This then remained similar in 2023 with 40 laboratories. So we can see that we've actually made an improvement. Next slide, please. And the final area that I would just like to flag that both EQA providers have noted is the laboratory should not report the presence of benign or likely benign variants. So this is your classifications of class 1 or class 2 for pathogenicity, because it can cause confusion to the clinician reading the report. Now, often laboratories make it very clear that a variant is pathogenic or likely pathogenic, but many reports we see are submitted that actually have a long list of multiple variants, and it is not clear which are benign or likely benign or those that are pathogenic. So a clear guidance is do not report the presence of any benign or likely benign variants. We saw that the KRAS gene, as I mentioned at the top of the call, that this is an optional test to report, but we could see that nearly 70% of laboratories did test for the KRAS gene variants, but not all of them reported the results, particularly when an EGFR variant was reported. Now, this day and age, when we see multiple genes being tested on single tests at the same time, it's important that you report the results of all the tests being tested, all the genes that have been included in your method. So if you are performing a KRAS test alongside EGFR gene testing, then it's important that these results are reported together. As I mentioned with case 1, we did see a large number of laboratories over-interpreting no actionable variant detected result and advising that the absence of an actionable EGFR variant, for example, indicated that the patient would be unlikely to respond to EGFR TKIs. This interpretation is inappropriate, and you really must use caution when you're reporting your cell-free DNA analysis, because we know that they have reduced sensitivity for detecting variants, and therefore you should either repeat a request sample so you can detect the presence of a variant if it's the sample has a higher content or circulating tumor DNA, or give a clear statement regarding the reduced sensitivity of plasma testing and that there's a real risk that maybe no ctDNA was present in the sample and therefore no tumor was actually tested. Next slide, please. So we often are asked, how does EQA demonstrate the benefit to patient care? And I think we can look at the data to start seeing where we see recurring errors happening. So participation here, again, we can see that a large number of participants are recurring participants on the left-hand side here, although we do see a number of laboratories withdrawing or having registered and then not submitting any results. So we know that some of these laboratories are setting up their assays, that they're using the samples for their validation, but really we recommend that if you sign up and register to the EQAs, we really would appreciate if you submit your results and participate in full. Performance on a year-to-year basis is dependent upon the clinical cases and the samples that we distribute, particularly the variant allelic frequencies. And here you can see, in general, the performance of the scoring for genotyping, interpretation, and clerical accuracy does remain high, generally over the 1.8 score out of 2, although here you can see, particularly in case 1, where no EGFR variant was detected or present in the sample, you could see a drop in the interpretation. And again, this comes back to reflect the over-interpretation of no EGFR variant being present. Next slide, please. Looking at the performance over the range of the years, you can see that really back in 2020, there was a high percentage of laboratories with critical genotyping errors. We were up over the 25% mark. And again, on the left-hand side, you can see that trends again about just the drop in the accuracy as well as the interpretation reporting over the years. So I think if you could put the annual scoring on the left-hand side graph into perspective, this year actually the standard had increased dramatically. On the right-hand side, again, you can see quite obviously that there's a drop in the number of laboratories with critical genotyping errors, which is your dark black dark blue columns here in the graph. So you can see that there's a continual decrease in the number of critical genotyping errors, although interpretation does vary, and that is reflective, as I say, of the challenging interpretation clinical scenarios that we submit to the laboratories. Next slide, please. Huge thank you not only to our long list of fantastic EQA assessors, which are listed here on the left-hand side, but also the team both in EMQN and GenQA, and AstraZeneca for the educational grant support to be able to provide these EQAs, and of course the participants, and many of you are on the call. Next slide, please.
I think we are on.
Oh, is that I thought there'd be a Q&A one.
Yeah.
Fab, yeah. Right, Simon, so are we going to open the question and answer session?
Yeah, we are. So I've got a couple of questions already teed up for you, Sandy.
Right.
While we wait for more questions coming from the participants. So, obviously, one of the values of this EQA is that we see a global perspective of the type of testing that's taking place within the context of lung cancer here. So, here we're asking laboratories to do a liquid biopsy test on a lung cancer sample, and the benefit of what we do is the fact we're sending the same sample to all laboratories, so we can really dig down into sort of technology trends and how those testing performs with respect to the different technologies. Have we observed any trends with respect to the number of incorrect results and the technologies used at all over the 5 years that we've been providing the CQA?
I think we can definitely see trends as a change in testing strategies. We definitely started off with more laboratories performing very targeted testing, for example, black box sort of methodology like your COBAS, etc. And we've seen a shift now into more next generation sequencing panels. And I think that's because the platforms are now available in the laboratories. But as you know, as an EQA provider of a global service, you have to be mindful that not every lab has access to high throughput automated systems. So you have to make sure that, and I think that's why we validate in the way we do as well, to ensure that even those labs using the not so high throughput technologies can still obtain reportable results and report correctly. With regards to trending of errors, that's a really difficult one, because we know that even though everyone's saying they're using exactly the same assay and exactly the same platform, nobody does it in exactly the same way. Everybody has their own tweaks and slightly different changes, even between people in the laboratories. And I think we don't see trends of issues. When we have seen trends of issues, then we talk to that manufacturer and make sure that we can actually address and help support those labs using that technology. I think there's just multiple different issues in laboratories. One of them, I think, is going back to laboratories don't understand their own limit of detection of their assay in their lab. Would you agree with that?
Yeah, absolutely. I would definitely agree with that. I think we have, it's very easy to just take a test and implement it in a validated manner without really still understanding how that test performs. And it's still very true that we see this not really understanding how the test works properly has been a considerable cause of mistakes or errors within the laboratory context.
Yeah.
Yeah, and I think also when you look at the results, and you presented some nice data there on just the breakdown of the types of technologies used, you can see that I know we bucketed it into NGS and target and LDT, etc. But actually, if you look at if the laboratory participants look at the data in more detail and look at the summary data, what you see is there's an enormous variety of different NGS tests within that bucket of NGS. That laboratories are using. So there's a massive variation in terms of how laboratories are taking these strategies.
And in fact, last year in the 2023 QA data, we counted about 50 different methodologies that were in use, without bucketing them into NGS and ddPCR. But then if you layer on the different ctDNA extraction methodologies on top of that, you probably have a million combination, or it seems to be, doesn't it?
Yeah, it does. I mean, I think when you look at the strategies in general, though, that there's not any one particular strategy laboratories are using to do this type of test.
No, and I think it comes from
It's
cost
very, very
and
true to say, there's a false, yeah, absolutely. It partly depends on what type of technology laboratories use,
yeah.
as they're just a general accepted technology within the laboratory setting. Do you think there are any trends in terms of seeing the same labs making mistakes at all?
Well, we do have persistent poor performance monitoring in place. So we do actually follow up with laboratories if they have poor performance, critical error that we've discussed in quite a lot of depth on today's webinar. But we also have monitoring in place from run to run. And that's where we can actually identify if there's an issue in the laboratory. And we give back a lot of feedback if people are, we went through a period of time that we saw a lot of people not actually using solid tumor tissue extraction methodologies rather than it being a plasma
Yeah,
based technology. So we can offer guidance and help and document review if that's also, or
yeah.
extra reference materials. And I think that's where the value of EQA rather than some maybe other proficiency testing provision varies, that we give a lot more educational help and support when labs need that. Yeah, I think
Agree
so.
that entirely. Um, one thing we haven't really touched upon in the webinar, but we certainly we've talked a little bit about it in previous other webinars, is the fact is this idea about how often you participate. Does that have an impact on your chance of making a mistake or improving your performance over time? Um, do you think there's any evidence to suggest that participating more than once or routinely, more regularly, and regularly, I think is a in quotes regularly is how often do you participate is a moot point potentially. But do you think there is evidence from your experience in the EQA world that regular participation does drive improvements in performance?
Absolutely. I'm going to say that the once assignment. Yeah,
You have to say it,
absolutely.
but
Um, I do. I mean, if I was the head of lab, I would want my laboratory to participate quite frequently and throughout the year in different EQAs because it gives you that assurance. I mean, the last thing you want is to put patient care at risk. Um, it's the balance of cost, the
mm,
capacity in the workforce in your laboratory, not prioritizing EQA samples over and above your clinical work, but also having that reassurance. And I think you've got to be pragmatic about it. But we do definitely see continued performance is continued participation improves performance, particularly when we are able to perhaps put variants in where we know are challenging for particular methodologies, or variants when we know are very rare and the laboratories don't come across it normally in clinical practice,
mm.
about giving that reassurance that when it does come through the clinical service that they are going to be able to detect it. So I think it has a value more than just saying you're accurate, you're testing. It's given that um, being open and having the exposure to rare variants, and also with the range of laboratories participating, you start seeing emerging new technologies coming through as well, and that's when you can start to learn what else is the new kid on the block and maybe
Yeah,
a better way to do the testing.
yeah, agreed totally. I mean, I think it's from an EQA participant perspective. So you, the audience, I don't know how much you consider how much time we put into the design of these EQAs, but
uh,
um, I think one thing that does stand apart in terms of what we're trying to do, and we've been working together on this for a long time, is that we put a lot of consideration into the clinical question we're trying to ask. So, each year we're trying to ask or address maybe a different trend or a different idea or a different problem associated with what we might have seen last year or the year before, and we come up with a new question to try and address it.
yeah,
So there's a lot of consideration put into the design of these EQAs. And so we don't ask the same clinical question every time. We don't send you the same sample every time. We are trying to really dig down into how the testing process works. And we design the EQAs really to address those issues. So
yeah,
I think this idea about repeated participation is important because without doing it on a routine basis regularly, in quotes again, I use the quotes between it, is you don't get to see all the clinical questions that might be asked in a real clinical context unless you do
yeah,
it more regularly. And it's sometimes overlooked, I think, that perspective.
yeah,
Maybe
yeah.
it's a nuance of what we're doing, but it's really we are trying to dig down into all the different questions associated with the clinical scenario.
So I've got a question coming for you then, Simon. So there appears to be a broad variation in the number of labs participating in this EQA across different EU countries. So Italy is very high,
Mhm.
Germany low. Do you think this is an indication of testing adoption or EQA participation?
I mean, we haven't done the detailed analysis, but I strongly think it's an indication of EQA participation rather than testing adoption.
Yeah,
Um, we between EMQN and GenQA, obviously we have a global coverage of many different laboratories, and I think probably between the two of the companies, we probably cover 3 or 4 thousand laboratories doing genomic testing globally. But within national context, there are still national providers of providing their own ecosystem. So Quip in Germany, for example, is a good
yeah,
example.
yeah,
So that would almost certainly explain why the numbers in Germany are low. Whereas in Italy, we have a very high presence in Italy, and also there's a very high number of laboratories in Italy
yeah.
uh, doing testing. I mean, it's a context within the testing strategy within those countries. So it's a reflection on EQA participation, but it's also a reflection on the testing approaches used in different countries, and they are very different depending on which the Europe, even within the EU, depending on which European country you go
And
to.
out with as well, I think places like in South America, etc., they tend to have large reference labs.
Yeah,
So the numbers might be low, but they will still be testing at volume. So it just depends the delivery model, doesn't it?
yeah, absolutely true, very true. Um, okay, so I think we've got another question which kind of relates to that as well. So I think we've covered
Yeah,
that. The
yeah.
Quip is the provider for
Um,
Germany.
I've got one for you, Simon, because this is something that we keep getting asked a lot. Is how low should we be going with our EQA
Oh,
samples? And I know we struggle with this because on the flip side, we need to make sure. I think with the EGFR testing, it's fine what we're doing just now. But I think in time there'll be clinical scenarios where we need to go much lower,
agreed.
and that will be the reason. We've always erred on the side that if you go too low and all the labs don't get it right, what's the benefit of the EQA? But I think it will come that clinically it's needed. How are we going to do that? And I don't expect you to have an answer because I don't think we do have an answer. But I think our challenge is also you can see the difference of what the participants mean of the variant allelic frequency is and what we're expecting as well. And I think that's a variation that we have to take into account.
Oh, it's a big dilemma, isn't it? And we've been the 5 years we've been providing this EQA, we've mulled it over on numerous occasions.
Mm,
Just looking at, for example, at the differential variant allele frequency between a resistance and a sensitizing variant in EGFR. We try to reflect real clinical life. So obviously you don't tend to find the resistance variant at the same level as the sensitizing variant. So I think I agree with you. We're going to have to at some stage push the barrier lower than we're currently challenging.
mm,
But it is always a trade-off between how many laboratories will fail the EQA as a consequence of that and what they do associated with that, and the educational feedback we provide. So we strongly believe in providing a service to the labs that's about education and providing support for those laboratories that need to know how to do the testing more accurately or whatever it is. And so if we catch too many laboratories out and they fail the EQA, there's a disincentive there for those laboratories potentially to come back in future years. Not for everybody, but for certainly for some, a good chunk of them as well. So I think it's a real challenge. And although we do have EQAs that are looking at more challenging variant allele frequencies, within the context of lung cancer testing, we are still seeing many laboratories failing at what we could consider a fairly routine variant allele frequency of just, less than 1% or about 1%.
1%, yeah.
I don't have an easy answer to it. I mean, we do put as I say, a lot of thought into the clinical scenarios, but not going to be easy for us moving forward.
Yeah, I agreed. It's our challenge.
It's our challenge. Yes, yes. Yeah, I agree entirely with it. I've got one question here. So now we've got 5 years of data. Are we intending at some stage to publish the results from the EQA?
I think we will. Yes, I think there's a lot of learnings there, and I think it's something that we can definitely build upon. Some of the data has already been published and out there, but I think we can start looking, particularly when we can see improvements, and I think that's a positive spin to get out into the published arena.
Agreed. Totally on that. Yeah, absolutely. Okay. I don't think we've got any more questions coming in.
No,
Uh,
oh,
oh, oh,
thank you.
here we go.
You're welcome.
You're welcome. Okie dokie. Okay. I've just got one more from one of our colleagues on the organising team. So I think it kind of ties in. No, actually, it ties in with the previous comment, which is really about this need for the EQAs addressing much lower variant allele frequencies. Where do you see that? Where do you see our strategy going for in the future with respect to that? So, we've already talked about the fact we need to do it, but are we going to be more comprehensive in terms of the other variants we include, or are we going to move to a more pan-cancer type approach for it?
I think we have to wait and see how the laboratories move forward. I think there'll be a mixed approach. I think there'll be a clinical need where you need to do a quick, accurate, low level test. And then I think there'll be a need when you do a full raft of a genomic profile. I think we'll just have to be responsive to what is needed. And it'll depend on that use case as well, very much
Yeah,
so.
brilliant.
Yeah. And again,
Okay,
we have to be mindful of who's testing what in each country too.
very true. Okay. In the absence of any more questions, I think what we'll do is we'll wrap it up there. A big thank you to you, the audience, for dialing in. Please do fill in that feedback form at the end. Do keep an eye out for the webinar recording, which we'll be signposting to you probably in the next couple of weeks via our usual mail shots and LinkedIn's for both organisations. It will be published on the EMQN and GenQA YouTube channels as a consequence of that. A big thank you to the organisers for all their hard work in terms of getting this all set up. A big thank you to my co-chair. I always like to thank my co-chair because this is definitely a double act, and
It
we
is.
work well in that respect. And thank you to you for dialing in. So do keep an eye out for where the results are coming up, and we'll see you at the next webinar. Thanks for your
Thank you.
attention. Bye for now.
Bye. Bye bye.
Bye.